Hello, my name is Rhonda Davis, and my project topic is on ransomware risk and mental and behavioral health care systems. This is a field that I've worked in as the interim executive director and director of information systems across the seven-county area, implementing new technology to be able to access EHR, electronic health records, and also be able to promote continuity of care and efficiently treat patients and provide patients with more access to care. So, with that being said, my topic here really focuses on the unique challenges that are present in mental and behavioral health care systems. So I'm going to start with my issue and risk statement. As mental and behavioral health care organizations continue to expand the use of digital records, telepsychiatry platforms, remote patient monitoring tools, and cloud-hosted case management systems, ransomware has evolved from a peripheral technology concern into one of the most significant enterprise risks affecting clinical care. What was once a threat primarily associated with financial downtime or billing interruptions, this has become a direct safety hazard in mental health treatment environments. Keeping in mind that treatment for mental health issues is a deeply personal issue and individualized to the person that is being treated. This shift is driven by the industry's increasing reliance on digital platforms for documentation, crisis tracking, medication management, and communication between clinicians, patients, caregivers, and interdisciplinary teams. From an IT governance perspective, this expansion of digital infrastructure requires stronger controls than many behavioral health systems currently maintain. The mental health and behavioral health industry as a whole lacks critical resources. And when I say that, um, typically the demand, um, 20 years ago, we thought the day that mental health care might become a crisis just in our society, which it has. And how do you make this care um, more accessible to individuals without compromising personal protected, HIPAA protected information? So simultaneously, enterprise risk theory demonstrates that ransomware is not merely an IT problem, it is a measurable business hazard with cascading clinical implications. Siegel notes that organizations must evaluate high impact threats using both probabilistic modeling and impact weighted decision metrics, particularly when human life and regulatory exposures are involved. Siegel 2011. In behavioral health, specifically, The integrity of digital storage is inseparable from the ability to deliver safe, informed, and ethical clinical support. The people we work hardest to protect are, unfortunately, the ones most vulnerable to system compromise. Because I have quite a bit of information to cover in a relatively short time, I want to I want to briefly discuss the risk statement. Mental and behavioral healthcare systems face elevated enterprise risk from ransomware because of high dependency on continuous electronic health record access, sensitive patient confidentiality requirements, telehealth expansion. And this one thing here is very, very important because before there was a wait to get counseling, and there still is a wait because of a in this industry, we used to say that one mental health professional could quit one agency and walk across the street and be paid more money. And today, the crisis is even worse. These conditions increase both breach probability and the severity of resultant operational, regulatory, and patient safety impacts. So, when you have a crisis, we don't have enough clinicians and mental health professionals, and basically, we're looking at information technology to fill in these gaps. It becomes a serious risk as a whole to the behavioral health and mental health industry. Research shows ransomware attacks on U.S. hospitals and clinics have tripled in frequency over the last 5 years, with behavioral health facilities disproportionately targeted due to lower security maturity and high value protected health information PHI. Riggy 2024 and Jiang 2025. Contributing factors to ransomware risk and behavioral health. Some of those, and elaborating on those contributing factors. Telepsychiatry platform dependency. This creates more remote entry points um, and a credential compromise risk. Legacy EHR modules lacking MFA patching. And when I discuss this, most of my background has been with a government and quasi state systems. So typically, they run a little bit behind when it comes to cutting edge technology. So these legacy systems are more prone to cyber attacks. And then also too, our our environment has just changed as a whole, especially with COVID. So you have more mobile clinicians using various networks and multiple platforms. With that being with the state, those systems were mainframe systems, and then with some of the providers, some of the larger providers, those were Windows-based systems, and then what I believe to be more secure were our Unix systems. And moving on, 42 CFR Part 2 confidentiality risk increases regulatory impact severity. And typically, there's poor training on cybersecurity risks for personnel as a whole. And there's a lack of offline backups, even though redundancy it was put in place. Um, Typically, any type of downtime resulted in a crisis. So I want to just touch briefly on existing data sources available in two model risks. So EHR, downtime duration and frequency, vendor logs, device age and OS versions and patch status, CMDB, asset management reports, MFA adoption by user role. Um, authentic authentication is very, very important, especially implementing dual authentication. Telehealth access patterns and fail login events. The telepsychiatry platform audit trails need to be frequently reviewed to detect any type of irregularities and like failed logins and authentication, past ransomware incidents, and dwell time. This is very important to go back and review like past incident to prevent future incidents from happening. And vendor security posture is very, very critical as well. And ISO 27001 attestations to ensure data integrity and prevent model distortion. Um, Cross-validate CMDB inventory against vulnerability scams. So basically, cross-validate databases that are online and being utilized extensively um, against vulnerability scans. User box plot outlier detection for downtime greater than 95th percentile. Apply cluster analysis to identify high-risk clinician groups with higher phishing set stability. Compare telehealth audit logs versus EHR access logs for behavioral abnormal detections. Remove incident logs where data gaps exceed 25% to avoid false weight. So, in my conclusion, ransomware in mental and behavioral health care is not merely an IT threat, it's a patient security, regulatory, operational, and reputational risk. It's very important, especially with IT governance, being able to bridge the gap between patient care, clinicians, and government policy and bureaucracy. MFA adoption, vendor risk assurance, and data integrity readiness is is crucial to safeguarding this data. This paper demonstrates that enterprise ransomware risk can be modeled through measurable variables, device age, patch cadence, MFA coverage, EHR downtime, phishing, EHR downtime reduction, phishing susceptibility, and telehealth vendor and their integration complexity with validated data sources and analytic techniques such as Monte Carlo simulation, logistic regression, risk heat mapping, and dwell time benchmarking. Organizations can quantify exposure and prioritize mitigation. Strengthening defenses requires enforcing MFA enterprise-wide, el- eliminating unpatched legacy devices, segmenting networks, requiring vendor-level disclosure, imp- vendor-level SBOM disclosure, improving trailing participation, and maintaining offline backups. The end state is a measurable analytics driven cyber risk posture where ransomware becomes containable rather than catastrophic.